Loani, welcome. My name's Ian Campbell from Palliative Care Australia, in Canberra on the lands of the Ngunnawal and Ngambri peoples. Welcome to Thursdays at 3, our regular series of conversations with people living and working at the end of life. Today, a conversation about the leading cause of death in Australia, heart disease, and work to improve the end-of-life experiences of people with end-stage heart disease. Dr Gursharan Singh is a research fellow in palliative care with the Cancer and Palliative Care Outcome Centre at the School of Nursing at the Queensland University of Technology. Her work has helped influence and helped change models of care, particularly within Queensland Health. Hello, Gursharan, how are you?
I'm well, thank you. How are you, Ian?
Well, thank you. Looking forward to our conversation today. And look, I should have mentioned that you were one of the finalists in last year's National Palliative Care Awards for the Emerging Researcher Award. Congratulations.
Thank you. Thanks.
Gursharan, heart disease. What are we talking about? There's around 190,000 deaths each year in Australia, most of them a result of heart disease.
Mm-hmm.
But what is it? I think of heart attack when I think of heart disease, but I think it's probably more than that. What is heart disease?
Yeah, that's a good question. I think when we use the term heart disease, I think it's really a broad term for lots of different types of heart conditions. And there are many different types, and I'm sure there are people have heard, such as heart failure, cardiomyopathies, and there are things like heart attacks, and there are also heart diseases where people are born with congenital defects in the structures of their hearts. So I suppose when we think of the word heart disease, it's a very broad term and a very broad types of diseases that can affect the heart. So, and lots of different types of therapy. So yeah, when we think of heart disease, it's a really broad term for lots of different types of heart disease.
And I imagine you're working with a pretty broad and diverse community as well. All sorts of people, all sorts of ages.
Yeah, exactly. But my research has really mainly been focused on people with heart failure, which is quite an unusual illness in that people living with heart failure, most of them are quite elderly, as we have the aging population, but there are also some people who are quite young who do have heart failure, which occurs sometimes. I know that they've had it develop after pneumonia, for example. They've developed a heart failure. And I think my focus on heart failure specifically has really come from the fact that people with this type of heart disease sort of experience a long journey with their heart failure. And also they experience quite a journey in that they can experience an exacerbation, and they can get quite unwell, go to the hospital, recover again, but they don't usually recover to the level that they were prior to that. And that can go on for many years. So it's quite an unpredictable trajectory. But as you mentioned, the heart attack and that sort, there is also always the risk of sudden cardiac death for people who are living with heart failure. So to answer your question, a lot of people that are older, but also quite younger as well. Yeah.
What are the symptoms that those people are living with? What does heart failure look like day to day, week to week, month to month?
Yeah, I suppose it really depends on how well their symptoms are managed. But the main symptom actually is breathlessness. People are living with shortness of breath. There are also other symptoms like feeling of fatigue, swelling in their ankles as well. And one that's really concerning too is anxiety. Anxiety and that comes from shortness of breath, feeling anxious that if you go out to do a certain activity, hang your washing or go to the shops, you could become quite breathless from that. And alongside that too is I suppose depression as well. That comes from feeling quite low mood, a bit depressed about the fact that you are living with this illness that causes shortness of breath and other symptoms that affect your confidence to go out and do your day-to-day activities. So quite a fair bit of symptoms that happen from heart failure, and of course it's all linked to other parts of your body, which it's related to your kidneys, and you get the swelling and so on. So yeah.
Of course. I mean, the heart, in many respects, is the engine room of our body, and if that's weak, if that's failing, then that
Mhm.
the ripple effect through our body. What is it that causes heart failure, or what do we know about that?
Yeah, I think there are a few causes from heart failure. Some of them, as I mentioned, are people developing heart failure after an illness such as pneumonia or even after a heart attack. But really, what heart failure is sort of a weakening of the heart, and sometimes it's also called cardiomyopathy, where the heart becomes enlarged and weakened. So it affects the heart's ability to pump blood at a level to meet the body's needs. So there are a few sort of issues that can occur that cause sort of that damage to the heart after like a heart attack or pneumonia, as I mentioned, or an illness, affects the heart muscle and weakens it, enlarges it, and affects its ability to pump blood to meet the body's needs. So, yeah.
Gursharan, what prompted your interest? Here you are, an emerging researcher working in Queensland. What prompted your interest in heart disease and palliative care and linking those two things?
If to answer that question, actually, it goes back to a long time ago.
Yes, it always does. There's always a
Yeah,
personal story. Yeah,
yeah.
absolutely. Yeah.
I was actually very interested in cardiovascular disease. I think from my memory, where it sort of came about was after a heart dissection in year 8 science class.
Really?
Yes, definitely. I just think I remember walking out of that science class being like, that was great.
Awesome.
I thought, wow, I really was able to dissect that heart with ease. And of course, there's a fair bit of cardiovascular disease as well in the family, and my grandfather was having a lot of cardiovascular disease when I was younger, so it was kind of nice. And from there I went on to do work experience in year 10, so just 2 years later, with my grandfather's cardiologist.
Wow.
Yeah. Yep. So I spent the week with him and followed what he did, and I got to go to the hospital and so on. And so from there, I was very much determined I'm going to be a cardiologist or of some sort. And so then I did my university degree. I did a Bachelor of Medical Science. And after the degree, the 3-year degree, I decided to do an honours year, an extra year. So during that year, I was fortunate enough to spend that year looking at a study which is the impact of breathlessness in people with heart failure and its impact on 30-day hospitalisation and mortality. And during that honours year, in my spare time, actually, I would just sort of read up a little bit about heart failure research, and I came across a lot of literature about people living with heart failure. They have quite debilitating and distressing and refractory symptoms like breathlessness and fatigue, and how much this impacts their quality of life, and the sort of challenges around providing palliative care for this group. So I suppose from there, after my honours year, I actually really sort of thought to myself, no, I don't think I want to do medicine. I don't want to be a cardiologist and treat the heart. I really want to be treating the whole person, for the person living with heart failure. And so that from there, I decided I'd like to do a PhD, and I told my honours supervisor that I think I want to do a PhD focused on palliative care for people with heart failure. And he said, okay. So I did the PhD, and as I, neared the end of the PhD, that's when I realized my passion is actually more focused on the person's quality of life as opposed to treating a heart illness, which would be, like the role of a cardiologist. So that's how I ended up where I am today. So yeah, it goes back to when I was in high school.
Great story. I love that, cutting up a heart in year 8 science has led you to this career, and the impact of your work started then. That's great. I remember that moment too in year 8 science, and my mates cutting up the heart and throwing them around the science lab. I'm glad you didn't do that though, and it inspired this great career.
Yeah.
Gursharan, what about the connection with palliative care? You mentioned that, I guess, treating the whole person is what drew you to palliative care and your interest in heart disease. Had you had any experience with palliative care prior to this work?
As in prior to commencing the PhD, do you?
Yeah.
No, actually, I hadn't really known what palliative care was. It was only when I just, took the initiative in my spare time to read a little bit about heart failure management, because as I mentioned, the honours year was all about breathlessness. So when I just was reading about breathlessness and other symptoms, there was a lot of mention in the literature around people living with heart failure have breathlessness, a poor quality of life, and there's challenges to, providing palliative care. And from there, that's when I sort of took my own initiative to read a little bit more about what is palliative care and what are they talking about in the literature for people with heart failure, because I just thought, at that time when I was, during the honours year, that people with heart failure, you treat the heart as cardiologists do, and that's it. And so from there, I kind of opened my eyes to reading a bit more about what is this palliative care they keep talking about for people with such, debilitating symptoms despite treating them.
Where are we at, Sharon, with, I guess, heart disease and palliative care and bringing those two together?
Yeah, I think there's probably still a lot of work to be done. One of that being that, research moves slowly, and the other being, of course, where palliative care is quite well established in for people with oncology, it's quite different illness trajectory compared to people who live with non-malignant illnesses such as heart failure, where, as I mentioned, the illness is quite unpredictable. There are periods of decline and so forth. And so I think in terms of where we're at with palliative care and people with heart disease, there's still a lot more work to be done. And so.
And you have had some influence. Your research has had some influence in this space. Tell us a bit about that. Queensland Health has really adopted this idea of palliative care and heart disease and making that work better. Tell us of the influence that you've seen and the change you've seen on the back of the research you've been involved in.
I think, recently, so in regards to contributing to the Queensland Health guidelines, with that, I was invited to contribute by the statewide heart failure service coordinator. So she reached out to me and asked me about, contributing to the section of heart failure and the palliative approach to care. So in the guidelines, I just sort of made some edits to make sure that it emphasises the importance of palliative care for people with end-stage heart failure as they experience the exacerbations, followed by periods of stability, with always having that risk of sudden cardiac death at any time, though. So therefore, the guidelines highlighted the importance of discussing treatment goals throughout the illness, and that being very important, but as well as prioritising quality of life over preventing disease progression for people during that end stage journey. And also just highlighting that this change in intent, it does include managing the increasingly emerging symptoms and the exacerbations, and as well as the importance of providing psychosocial support at that critical time for the patient and the family. So mainly that was around involvement and an invitation through the Heart Failure Services Coordinator to look over those end-stage heart failure guidelines and just contribute to that section around the palliative care importance.
It's awesome work, and I know that work like that, change like that, takes time for the benefits of it to really materialise. But what have been some of the early benefits that you've seen? What have patients, what have families been saying? What have doctors and nurses been saying about that more palliative approach to end-stage heart disease?
Yeah, I think I have actually been involved, to answer the question around what do sort of patients say about this, I have been involved with the Queensland Heart Health Consumer Advisory Group when I've been thinking about, research and where to next. I've had conversations with them, and they're a consumer advisory group who are really a team of people living with heart failure. And I went to one of their meetings and I said to them, one thing I think would be really good is if we could assess palliative care needs. I did mention to them it was palliative care needs, but obviously I was there to sort of make it a bit more clear what do I mean by palliative care needs. And so there is a heart failure tool that I sort of showed them, and it's to ask the questions about are you having troubles with your symptoms of breathlessness at home? There was heaps of questions on there, but touching on various things like, do you need more support with your daily activities, showering, toileting? Do you need more information about your illness, managing your medications? And how is your caregiver as well? Do you have the supports that you need? So I posed this to this consumer advisory group, and they were actually quite receptive of this. They were saying they really do need something like this. And they did say to me, I remember one individual told me, I won't forget it, but she said, yeah, I went to my appointment with my cardiologist and he said, how are you feeling? I said, I feel awful. I feel terrible. And he said, okay, on to your medications. And she was just saying that he just sort of glossed over the fact that he didn't ask, what do you mean by have you been feeling awful? And and it was just straight to the tablets is what she said. So that there's been generally quite receptive to sort of having those broader conversations about how are you feeling. On the flip side, though, with health professionals, I know that they are quite receptive to this, but the trouble is, of course, for that cardiologist in that instance who that patient was referring to, we can only imagine that how busy he would have been that day to have that conversation. And all the patients have said that to me, my cardiologist is busy, it's busy, busy, busy. And so when do I have that conversation? And so I think that's that's an interesting thought to think about around how can we support, patients with their illness overall, holistically. These people are people with their own lives. They have grandchildren and so on. But there is no sort of discussion around these sort of things. And I suppose on the flip side, it is how can a health system sort of address those with the pressures that health professionals are experiencing? Exactly. So I think that's the overall sort of perspective that I've received from patients and health professionals. So it's an interesting dilemma, I suppose.
Really interesting. Those conversations about palliative care and end of life and quality of life take time. But how do you find the time in a busy health system, in a stressed health system?
Yes.
It's equally an issue we hear from the primary health sector as well, Gursharan, around the time that those conversations take. Everyone sees the value in doing it, but they don't necessarily have the time or are remunerated to have these sort of conversations as well. What happens, Gursharan, when palliative care gets mentioned? Do people freak out? Is there that sort of sense that you're giving up hope? I'm about to die. Is that one of the challenges that you've seen in these conversations?
Yes, definitely. When I spoke to the members of the Heart Health Consumer Advisory Group, they were saying, it's all about understanding, though, isn't it? So when you hear palliative care, when people hear palliative care, it's really like, oh, I'm not dying and so on. But when I sort of present to them the tool and say, this is the questions that someone would ask you, and this is about palliative care because this is about your quality of life, that's when people are more receptive to it. So throughout my research, I've come across a lot around the terminology palliative care, and should we change it to supportive care? That comes up a lot. But I remember many years ago I spoke to Professor Mira Agar as well, and I was talking to her about this topic, and she was saying, it's semantics, because if we change the word to supportive care and the meaning of supportive care remains as death and dying, then what have we really changed if we don't change the understanding first? So I think, to answer yes, but it's a matter of an understanding of what palliative care is. And definitely death and dying is a component of it. But I think very much based on the World Health Organization definition that palliative care is addressing physical, spiritual, emotional, psychological concerns for people who are facing a life-limiting illness such as end-stage heart failure or heart failure in order to improve the quality of life. So in my understanding, it's not just death of dying, it's broader than that.
Well said, and a shout out to Mira Agar, the chair of Palliative Care Australia. And I think the work of you, the work of Mira, conversations like this, bit by bit, we raise awareness about palliative care and the full scope of palliative care and the social, emotional, the medical, the physical, the full scope of palliative care. Gursharan, just one of the other, I guess, misconceptions about palliative care is that it's only for that, those last weeks, those last days of life. Through your research, through your work, have you been able to identify the benefits of, I guess, being referred to palliative care much sooner, much earlier in someone's heart disease trajectory? Have you been able to get a sense of the value of earlier referral to palliative care?
I haven't actually directly seen myself firsthand the benefit of earlier referral to specialist palliative care for people with heart failure, although there is documented evidence of that in the literature. But I think something that I was also thinking about recently in terms of improving palliative care for people living with heart failure is whether the solution is greater referral to specialist palliative care, because it's tricky, isn't it? Because we know globally specialist palliative care is an underpowered specialty. And so I think, there's a lot of, it's interesting just to talk about the benefit of earlier referral to specialist palliative care for people with heart failure. I think that's an interesting area, and whether that's actually feasible is something to consider with already just quite an overwhelmed workforce of specialist
with a stressed health
care.
system.
Yes, absolutely.
Exactly. We hear that often. People do see the value, but the access just isn't there because the health system just can't cope.
Yeah, and I think in response to that, I have thought about what are the current gaps in that for people living with heart and end-stage heart failure where specialist palliative care is overworked. Well, then what can we do to enable earlier access to palliative care for people with heart failure, and how can we enable that to occur rather than saying, okay, let's do earlier referral to specialist palliative care, when specialist palliative care might be saying, oh no, I can't cope with that. So I think one way to sort of think about how we can overcome that challenge is thinking about the importance of the usual cardiology treating team and even people like the GP, and ensuring that these health professionals have the skills to recognise and manage difficult symptoms, and then reserve specialist palliative care for individuals with more challenging or complex needs. But I think in order for that to happen, these health professionals like the treating cardiology team and the general practitioners should have the training and feel competent to recognise the needs of patients and their carers to provide that person-centred support. There's also the issue around people with heart failure having ICDs, so implantable cardioverter defibrillators. And it's important that health professionals as well are also empowered to have conversations about ICD deactivation, which is all part of palliative care, I think, which is around having those conversations about planning goals of care, people's preferences, and so on. So there are times where I think ICDs are inappropriate in the dying phase, or while someone has an active not for CPR in place. These are all indicators that, health professionals need to have the skills and the time to regularly discuss the risk and benefits of ICDs. And so I think overall the solution would be making palliative care everyone's business for people with heart failure, and addressing those unmet needs. But then on the other hand, referral for individuals with more complex needs. But we also need to do more work on what are complex needs. What does that look like? More research is probably needed to know about who should have a referral to specialist palliative care, because they're such a finite resource, I suppose.
Well said, Gursharan. I think those palliative care skills need to be across medical disciplines, across the health system, but particularly within primary health, with GPs, with nurse practitioners. We need to upskill everyone in those palliative care skills, and so that the influence of palliative care can be felt more broadly by more people earlier. Well said. Gursharan, what next for you? What are you working on at the moment?
So at the moment, I am currently working on getting a study up and running, actually here at the Prince Charles Hospital in Brisbane. So what I'm planning to do, or what I've been fortunate as well to receive some funding for, is in regards to what I mentioned earlier with my conversations that I had with the lived, we call here in Brisbane, we call them lived experience advisors. So the members of the Heart Health Community Advisory Group. From my conversations with them over the last 2 years, I've managed to receive some funding for the Prince to implement this study at the Prince Charles Hospital, which will involve a designated heart failure nurse assessing patients with heart failure and their carers for unmet needs. And then having a discussion about how these needs can be addressed, and then making the appropriate actions and referrals, and then communicating this to the treating cardiology team that I've assessed this patient, this is their unmet need that they've identified, and this is the action that we've taken. And one thing that I really like about this research, which came from the input from the members of the Consumer Advisory Group, is that they said that they would like to receive the questionnaire while in the waiting room and highlight the concerns themselves that they would like to talk to the nurse practitioner about. So they thought that would be a really good idea, which I quite liked. And, you never think of these things till you talk to people. And they said that they would like to bring up the concerns rather than have the heart failure nurse go through every concern.
Yes.
They wanted to be the ones to say, this is what I want to have a chat today about with the nurse. So very exciting. And so hopefully that'll be up and running quite soon.
Awesome. When the voices of lived experience are involved from the start, the results are so much stronger, so much more meaningful. It's great work you're doing.
Yes, definitely. Thank you.
Thank you so much for spending this time with us. Often, palliative care and cancer and oncology have a strong history, a strong link, but palliative care is for all life-limiting illnesses, heart disease, dementia, Parkinson's disease, and you've helped us broaden the scope, broaden the meaning of palliative care today, and indeed your work does that every single day. Gursharan, thanks so much for your time this morning. Thank you.
All right, thanks, Ian.
Dr Gursharan Singh, Research Fellow in Palliative Care with the Cancer and Palliative Care Outcomes Centre at the School of Nursing at the Queensland University of Technology. Thanks for tuning in to Thursdays at 3, whether that's via PCA socials or Spotify, and engaging in matters of life and death. You'll find advice, tools and support at the Palliative Care Australia website, where you can also make a donation to support our work. See you next time.